Okay, so this thesis is really why we are here today to talk about this. This is the original thesis by Wilson's. My talk is going to be slightly hepatocentric, but I'm hoping to cover both the issues in terms of the treatment as well as the monitoring. And really, when we talk about treatment, we have two so-called principles. One is to reduce the excess copper which is there and put the patient in so-called negative copper balance, that is, put it below, put a child or adult bit in the subtoxic threshold. And for that, the drugs usually used, which we have, are penicillamine we get that very easily, and occasionally triantine. And the question after that is, once you have done that, how do you maintain lifelong? And again, you can use penicillamine and continue maybe in lower doses along with triantine or zinc. Now, the problem with this management, and that's a problem we're going to have tomorrow when you talk about the consensus, is there is really no consensus when you talk about management. When the Wilson's groups which are working with Wilson's disease were asked, how do you treat a patient with Wilson's disease? These are the answers that they got. They varied from country to country, institution to institution, and they were asked, why do you use this, or what made you decide on that? Again, the answers are very different. This is easily available, this is not available, this is our experience, something is expensive, and really in India we are exactly where we are today. We will treat it as based on our experience, as long as you do not violate grossly what are the so-called guidelines that are available. So let's talk first about the hepatic, and as I said, it's going to be more hepatocentric. If you have a person with acute liver with encephalopathy, from our discussions we generally know most often they would require a transplant. While waiting for the transplant, you could put the patient on either penicillamine with or without zinc, and that's a matter of discussion. Some people will do both. In fact, quite a few institutes internationally would put both, but you could use one. But really, this could only be a bridge. You're finally required to have a transplant. When you have acute liver failure without encephalopathy, as has been talked about, you have the King's College to decide whether you want to put this person. It's going to be a regular follow-up, and based on the King's College, you may decide to go in for a transplant or not. When you have picked up people, either there is asymptomatic transaminitis or asymptomatic normal liver function tests, or you picked up a neonate by screening, because now with genetic testing, all of these are possible. Zinc seems to be the way to go, and I don't think there is too much of a controversy over here, though someone may have the difference of opinion. The controversy slightly maybe is, okay, if you do pick up by genetic methods a neonate who has exactly the same mutation as the sibling, and I know that for Wilson's, when is the earliest time that you want to put this person on zinc? And that is still not very, very clear. A lot of people would put it around the age of 2 to 3 years, only because of the reason that you don't get Wilson's presentations much before that. So this is again more, there's no scientific evidence for giving it at 2 years or 3 years, but this is just a general feeling that that's the age at which you would start. When you have the chronic liver disease situation of intermediate severity, and that's where the problem is, whether you would like to start on penicillamine, whether you want to start on triantine, or whether you want to start on zinc. And I'm not going to go into the details because this is really a take-home message. So we know that there are chelators over here and zinc on the other side. We also know the difference in the costs. We also know the difference in the side effects. So where would I, or where would we at KEM Hospital decide what to use? We would, as has been mentioned, use penicillamine for almost all the patients. There may be a few exceptions. If there is a very severe thrombocytopenia, and when I talk about very severe thrombocytopenia is because of various reasons, the liver disease, hypersplenism, and levels as low as 10 or 20,000, we may be a little reluctant. 50, 60,000 is not something that we will be worried about at all. If there is a very significant renal disease along with the liver disease, because we are worried about penicillamine, to start penicillamine when there is a renal as well as a liver problem, you may think, okay, penicillamine is not the way to go. You may decide on maybe putting the person on triantine. Obviously, when there is an intolerance and you cannot use penicillamine, you may use triantine. And neurological is again a question of opinion, whether it's as good, as bad, is there more deterioration. And as been mentioned over here, those in USA would primarily, they don't even use penicillamine, they would go triantine for everything, while in the Europe, most people would use penicillamine. We would, based on what we have discussed today, penicillamine seems to be the way to go, even for the neurological. I'm not going to talk too much about zinc because we have a talk on zinc just after me, so I'm not going to sort of take space of what the speaker is going to be. But we would generally use zinc. We use zinc as co-treatment. So we would put penicillamine plus zinc in all our patients. Is there good evidence for or against? No. We definitely use zinc in pre-symptomatic cases. We use zinc as maintenance therapy. and recently shortage of penicillamine. We have got a lot of experience in using of zinc the last 6 to 7 months, and of course the neurological way to go. The point to remember over here is the outcome of patients, of even liver patients, whether you are an adult or a child, differs. The adult data suggests that if you have a hepatic presentation, you require chelators mandatorily. This data is not true in children. Children with mild or even sometimes mild to moderate liver disease have shown very good response to using zinc. So there is a little bit of a difference depending on the articles where you read what your outcomes may be, and you have to ensure that you are reading the appropriate article for the appropriate population that you are reading. Coming to the monitoring, why do we need to monitor? There are various reasons. Of course, the most important is to see that what you are treating the patient is actually making a benefit to the patient. So there is a clinical and a biochemical improvement. That is the most important. You also want to know is at what stage is he effectively decoupled. Are there any good tests for that? Because that's the time you may decide either to lower the dose of penicillamine or maybe change over to zinc. So unless you have that good evidence at that particular time and some markers to tell you, you are going to have a problem in making a decision. You want to ensure when they come for regular follow-up that they are compliant. You don't want to suddenly find that they stop coming, or just because they're coming to you as a visit once a year, just before coming 1 month before or 2 weeks before they start taking the medicines, after they go back from you, they stop taking again for the next few months. You want to look at side effects, and again I'm not going to talk too much about side effects because that's going to be talked about later. And there are some situations where you are not 100% sure that this is Wilson's disease, but the child is not doing well. You have no other alternative left, and sometimes clinically we have all faced the decision is you have put the patient on penicillamine, taking the decision, okay, this may be Wilson's disease. But there is a time which you have to decide, is that penicillamine or whatever medicine you are giving useful or not useful. And if not, and there is further deterioration, you need to again come back and review the diagnosis if necessary, if you don't have 100% diagnosis. So the plan is really divided into clinical, the biochemical and the urinary. Now clinical is, we are of course looking at the liver status, but what we are looking at is a good clinical examination, hepatosplenomegaly, ascites, signs of decompensation, growth, etc., especially for children. You are looking at side effects, and there are a lot of side effects. And you are looking at KF rings because you definitely know that KF rings disappear on treatment. It may take 4 years, 5 years, up to 10 years, it's variable. But it does go away. And if it goes away, it's good because you know that there is usually patient is been effectively decoupled and the copper load has gone down. On the contrary, also if a KF ring has gone and has come back, you know that there is some problem with compliance or with medicines, and you need to be careful about that. Biochemically, you are looking at primarily from the point of view, of course, side effects. And this is primarily true for penicillamine because we know the commonest side effects that we see, especially when you initially start, is bone marrow depression. You have problems with the urine because of nephrotic syndrome and urine related problems. And you're monitoring the liver functions from a hepatic patient point of view. If there is a hepatic patient, find out whether they're improving or not. However, the point to remember over here is hepatic improvement or biochemical improvement takes years. And sometimes the data again from King's College, but most of them will show you that it can take as long as 7, 8 or 9 years for normalization of a liver function test in children. And sometimes even at the end of the stage, the patients are doing very well, they are extremely well controlled, they are happy, but if you do their SGPTs, they are still. So do not expect reduction or dramatic improvement in the liver function test in a matter of a few days. Lastly, looking at what's happening to the copper. Is it effectively decoppered? Is the copper coming out? For that, urinary copper is the way to go. The problem with urinary copper is an excellent marker to find out how much amount of copper is coming out. But as long as you have a very reliable way of measuring it. If you don't have a reliable way of measuring it, your copper levels are going haywire. And you will see patients being reported of very good penicillamine doses started in 3-4 months and the urinary copper levels of 50 or 60. I mean, that is just impossible. There is obviously a problem in the urinary copper measurement. You won't get that levels in the first month or 2 of treatment when they're taking appropriate, correct doses for good medicines. Serum-free copper is something that is very often talked about, not in the patient of diagnosis, but in the patient of monitoring the child or monitoring the patient. Is he getting effectively decoppered or not? It is not measured. It is calculated. It is calculated based on your serum copper. It is calculated based on your celluloplasm. So celluloplasm into 3. You minus that from the serum copper and you get the serum-free copper. Our personal experience is that again the values are all over the place. You get negative values, you get positive values. Again, if you are measuring ceruloplasmin very accurately, you are measuring serum extremely accurately, that may be the way to go. I am not too sure how reliable it is and how often people are using it. We did start using it, but now we really don't depend on it to that particular extent. More important is trying to know is urinary copper. We all do urinary coppers, and I talk about this all the time. We use urinary coppers in all our patients of Wilson's disease and a follow-up. Do we know how to interpret it? And that is very, very crucial. The first point to understand is urinary copper interpretation depends on whether it is on chelator or whether it is on zinc, because the values are completely different. If you are on a chelator, you would expect values initially very high, more than 500, usually more than 1000. And if you are measuring the serum-free copper, often it's going to be very high. When you are reasonably well controlled over a period of time, your urinary copper will drop to 200 to 500. Your urinary copper of a patient with Wilson's disease on chelators will never come back to less than 100, which is normal. So don't expect it to drop less than 100. In fact, if it has gone less than 100, there is a problem. Either your dosage is inadequate or the patient has got copper deficiency. So your levels will have to be between 200 to 500. A best way really to find out is whether your patient is effectively decoppered or not is while he is on penicillamine, stop the penicillamine for 48 to 72 hours, then measure the urinary copper. If he is effectively decoppered off penicillamine after 48 to 72 hours, if his urinary copper is less than 100, you are generally showing that there is a reasonably good compliance and is effectively decoppered. And that to me is really the best way. Again, you require a good measurement of the urinary copper, but that's the way to go. When there is non-compliance, you could have urinary coppers which are very low, because if he is just not taking a chelator, when you stop taking a chelator a month or two before he comes to you, your urinary coppers are not going to be very high. In fact, they are going to be on the lower side, because there is no chelator taking the copper out and there is no copper that is there deposited for the copper to come out. So even a low urinary copper sometimes can be managed, can be a listing of non-compliance. Or even suddenly a very high urinary copper can be non-compliant. He is not taking medicines for 6 months. He knows he has to come to your place for a visit. 1 month before the visit, he suddenly starts taking his medicines. His copper is again going to shoot up very high, 500, 800,000. So it's very difficult for a urinary copper to really judge either a low or a high, both of which can be non-compliant. It all depends on sometimes making a history and the examination and finding out how are the other parameters along with your urinary copper before you decide whether it's useful or not. If you are getting a good serum-free copper, that would be great, because that can differentiate from compliance problems versus treatment-related problems. Over-treatment is generally going to happen after years of therapy. You should not think about it initially, and I'm not going to go about it in detail. But contrast this if a patient is only on zinc and not on any chelators. Your values are different. On zinc, a good control level will not, the urinary copper will be very high, but it won't be extremely high. It will be actually really around the range of 100 points. So it will be not as high as you expect. A good control of urinary copper on zinc is less than 75. The same for when it's on chelator is very high. So see the difference. If you don't know what treatment is taking, you will not be able to sort of find out or understand what these levels mean. Non-compliance is also very different. Normally when you take zinc and you are only on zinc, your urinary excretion is should be more than 2000. We never did urinary zincs for 6 months while we are doing a patient. Since in the last 6 months all our patients are on zinc, we have started urinary zinc collection, very, very simple method of urinary zinc. Do it along with the urinary copper and you will surprise yourself. In fact, the zinc which we are using, the urinary zinc levels are 2000, 3000, 4000, 5000, extremely high. So at least we are sure that the copper, that the zinc that we are using is beneficial and there is some zinc in it. The reason behind is 7-8 years ago when there was a zinc preparation in the market which we were using and that was tested, was found to have 0 zinc, though it was supposed to contain a lot of zinc sulfate. So really to summarize, chelators are the mainstay of therapy for hepatic disease, and I also for neurological, but in neurological there is an option of using just zinc, which is not really the way to go in hepatic presentations unless you are a child and you have mild problems, then you can have zinc alone. Zinc definitely has a role in long-term treatment, there is no doubt regarding that, and if you have a good zinc preparation and you are monitoring that zinc is adequate enough coming out in the urine, so you are sure that the zinc you are giving is effective, that's good. Monitor is extremely crucial, monitor for side effects, monitor for improvements, but beware that improvement takes a long period of time. So don't get unnecessarily worried, 1 year of treatment, SGPT is still not normalized, is something going wrong. have wasted time. No, that's not. You have to expect that. And urinary copper, if measured accurately, is a very, very good indicator to find out the copper balance. It is the way to go, but you need to understand and know that it varies whether you are taking a chelator or you are taking zinc. Thank you.
Thank you.